Hello, everyone. I am Bishra Jangit, and today I am with Dr. Salinger, Associate Professor of Surgery from University of Maryland, an expert in the field of perioperative blood management in cardiac surgery. And notably, he recently published a comprehensive ERAS Cardiac Society turnkey order set for blood management. Thank you, Dr. Salinger.
Thank you for having me.
And today we will be discussing the postoperative bleeding when to re-explore. So Dr. Salinger, in the context of postoperative bleeding after cardiac surgery, could you share your perspectives on the most relevant guidelines and protocols for deciding on a patient's return to operating room?
Sure. So we talk about guidelines of when to re-explore, and there's some general guidelines that we teach people, and I think all of these need to be taken in the context of the clinical scenario and the judgment of the surgeon and the team treating the patient. But in general, when certainly we should think about re-exploring post-operative patients if the bleeding it hits about these parameters. So if you see 400 milliliters for 1 hour, 300 for 2 hours, or 200 for 3 hours consecutively, and the patient is not coagulopathic, then you have to be highly suspicious, and most likely there is a surgical cause of the bleeding. And I certainly think there's patients that need to go back to the operating room before they hit those thresholds. So I don't think you necessarily have to wait for those thresholds, but certainly if you see that kind of bleeding, and particularly if it's not in a coagulopathic patient, then you should be taking the patient back to the operating room.
Okay, thank you.
The corollary of not just looking at chest tube output is that you can see patients who bleed and then the bleeding stops, but then they still need to go back to the operating room for tamponade. And in the early postoperative period, almost any time you're getting called to see a patient with a problem, the top 5 things on your list should be making sure they're not bleeding or having tamponade. And once you've ruled those out with a quick evaluation, you can move on from there. Some of the ways we see tamponade present in the early postoperative period are certainly with hypotension or escalation of vasoactive drips to maintain the blood pressure or the cardiac output. Oftentimes, but not always, you'll see equalization of the PA diastolic pressure and the central venous pressure. The times when you have to suspect it are patients who come out bleeding a lot and then suddenly it stops. Often these are people who have a coagulopathy, it gets corrected, and then as you correct it, the chest tubes can clot off, and sometimes you'll get a lot of blood that pools in the chest, and it doesn't take that much to exert pressure on the heart. Or even if you don't see a sudden cessation of bleeding, if the patients are bleeding and then they become, after they stop, the bleeding kind of settles down, but they become less clinically stable and you're going up on your drips, you should suspect tamponade. And a lot of people will get a transesophageal echo at this time to see if they see something on the heart. But there certainly can be situations where you won't see it on the echo, and you just have to go with your clinical impression and re-explore the patient for tamponade.
Okay. And a next question is, where do you see a need for further guidelines for bleeding?
That's a good question. I think one of the areas that we still have not perfected and are able to give perfect guidance is the timing of re-exploration for bleeding. I think as a society, we really need to work on giving guidance so that we're not waiting too long to take patients back to the operating room. The way surgeons and their teams get graded now, re-exploring a patient for bleeding, it is a negative outcome in your overall dashboard. And while that is a negative event, what that incentivizes is sometimes you'll see patients that are not re-explored and instead they're given a lot of blood products, and that may not be the best treatment for the patient. So if we could come up as a specialty with objective better objective criteria regarding the timing of exploration. Because if the patient is going to be re-explored, most likely the sooner they get re-explored, the better they're going to do, the sooner they can get back on the right pathway to recovery.
Great. Thank you, Dr. Salinger, for
Thank
sharing your
you.
perspectives.